All right, good afternoon. Welcome back from our break. Our next panel is Data Digest, COVID-19 Vaccine Effectiveness. In this session, we'll hear from Commander Heather Scobie, who will present COVID-19 incidence and death rates by vaccination status during periods of Delta and Omicron emergence. Then Dr. Ben Summers and Dr. Lok Wong Samson from HHS Office of the Assistant Secretary for Planning and Evaluation will present an analysis of county-level vaccination rates and COVID-19 outcomes in Medicare beneficiaries. Dr. Wafa Tarazi is also joined and will be available for questions and discussion. Dr. Scobie, are you on? I see you. Your slides are up. You have the floor.
Thank you. Good afternoon. Next slide. Previous reports of COVID-19 case, hospitalization, and death rates by vaccination status indicated that protection against infection, as well as against serious COVID-19 illness for some groups, declined with the emergence of Delta and waning of vaccine-induced immunity. During August to November 2021, CDC recommended additional primary COVID-19 vaccine doses for immunocompromised persons and booster doses for those persons aged 18 years and older. The SARS-CoV-2 Omicron variant emerged in the US during December 2021, and by December 25th, accounted for 72% of sequenced lineages. Next slide. To assess the impact of vaccination with additional and booster doses, hereafter referred to as booster doses, we assessed data reported from 25 jurisdictions that routinely link case surveillance and immunization data and represent 62% of the total US population. Averaged weekly case and death rates and incidence rate ratios with 95% confidence intervals were estimated among unvaccinated and fully vaccinated adults by receipt of booster doses. IRRs were used to estimate vaccine effectiveness using the formulas shown to aid interpretation of results. We assessed rates during 4 periods defined based on variant proportion estimates in the US. Pre-Delta in April to May, Delta emergence in June, Delta predominance during July to November, and Omicron emergence in December. Close to 9.7 million COVID-19 cases were included with a positive specimen collection date during April 4th to December 25th, 2021. And over 117,000 COVID-19 associated deaths among cases were included through December 4th to allow the lag associated with this indicator. Next slide. These graphs show the weekly trends in age-standardized incidence of COVID-19 cases on the left and deaths on the right. Unvaccinated persons are shown in black, fully vaccinated persons overall with open circles, and fully vaccinated people without booster doses in light blue and with booster doses in dark blue. The colors in the background of the graph show the periods of variant prevalence with pre-Delta in white, Delta in blue, and Omicron in gray. Peaks in age-standardized case and death rates occurred during August, when Delta comprised 95% of circulating viral lineages, and another peak in cases occurred during the weeks ending December 18th and 25th, which were 39% and 72% Omicron variant, respectively. The rates of COVID-19 cases and deaths were lowest among persons fully vaccinated with a booster dose, higher in those without a booster dose, and much higher in unvaccinated persons. Next slide. These graphs show the weekly trends in age-standardized incident rate ratios of COVID-19 cases on the left and deaths on the right. The ratios are shown for unvaccinated persons compared to fully vaccinated persons overall with open circles, fully vaccinated people without booster doses in light blue, and with booster doses in dark blue. The background color again relates to the variant period, pre-Delta in white, Omicron in blue, Delta in blue and Omicron in gray. Case IRRs during the pre-Delta and Delta predominant periods were relatively stable, followed by declines corresponding to the transitions in variant prevalence. Death IRRs changed little over time. Differences in the IRRs between fully vaccinated persons with and without booster doses decreased over time. However, booster doses consistently provided more protection even during Omicron emergence. Next slide. In terms of quantifying those differences compared to fully vaccinated persons with a primary series, unvaccinated persons had 14 times the risk of COVID-19 infection during the pre-Delta period, representing a crude VE of 93%, 9 times the risk of infection during Delta emergence, or 89% VE, 5 times the risk of infection during Delta predominance, or 80% VE, and 3 times the risk of infection during Omicron emergence, or 68% VE. Unvaccinated persons also had over 15 times the risk of COVID-19 associated death before and after the Delta emergence, which represented a VE of 94 to 95%. Next slide. Next, let's see. Can you go to the next slide? Next slide again. Here we go. Thank you. Next, if we focus on the October to November period when boosters were provided and Delta was predominant compared to fully vaccinated adults without a booster dose, unvaccinated adults had 4 times the risk of infection, or 75% VE, and 13 times the risk of COVID-19 associated death, or 92% VE. Compared to fully vaccinated adults with a booster dose, unvaccinated adults had 14 times the risk of COVID-19 infection, or 93% VE, and over 50 times the risk of COVID-19 associated death, or 98% VE. During Omicron emergence in December, unvaccinated adults had 3 times the risk of COVID-19 infection, or 64% VE, compared to fully vaccinated adults without a booster dose, and 5 times the risk of infection, or 80% VE, compared to fully vaccinated adults with a booster dose. We also noted that booster doses provided the largest gains in protection against persons aged 65 years and older, followed by 50 to 64 years, compared with those 18 to 49 years. Next slide. This analysis had several limitations. Because of the reporting lag in death data, the influence of Omicron and COVID-19 associated deaths by vaccination in December could not be evaluated. Booster doses could not be distinguished from additional doses in immunocompromised people. This was an ecological study lacking multivariable adjustments, and causality could not be determined. Possible differences in testing, immunity from previous infection, waning immunity, or prevention behaviors by age and vaccination status might partly explain the differences in rates between groups. And the trends were likely affected by temporal changes in testing or reporting. National variant as prevalence estimates were used, but prevalence differed by jurisdiction over time. Variable data linkage completeness might have resulted in misclassifications that could influence IRR estimates. Finally, the data represent 62% of the overall U.S. population and therefore might not be generalizable. Next slide. So this early analysis of surveillance data provided crude signals of VE that were consistent with other published studies reporting decreased VE against the Omicron variant compared with Delta, and increased protection from booster doses compared with a primary series of COVID-19 vaccination alone. A study showed that COVID-19 case and hospitalization rates among unvaccinated persons in Los Angeles County were 4 and 23 times those among fully vaccinated persons with a booster dose during Omicron predominance. 2 studies estimated a VE against infection or symptomatic illness caused by Omicron of 67 and 68% for 3 mRNA doses, and 3 studies estimated a VE for 3 mRNA doses against COVID-19 associated hospitalization was 90% or higher during Omicron. Next slide. Ongoing analyses will help monitor the impact of the Omicron variant and other emerging variants on VE against COVID-19 cases and associated deaths. Rates by vaccination status will be updated monthly on CDC's COVID data tracker website. And this visual is a screenshot of that site. Next slide. In summary, COVID-19 vaccination protects against SARS-CoV-2 infection, even as the Omicron variant became predominant, though decreases were observed in case RRRs for unvaccinated versus fully vaccinated persons with and without booster doses in 25 U.S. jurisdictions during December 2021. Protection against infection and death during the Delta predominant period and against infection during Omicron emergence was higher among booster dose recipients, especially among persons aged 50 to 64 and 65 years and older. All eligible persons should stay up to date with COVID-19 vaccination. Next slide. I'd like to acknowledge the following staff from CDC and collaborators from these health departments. Thank you.
Thank you, Dr. Scobie. Again, very good information that we need to continue to get out to the public. Next presenters will be Dr. Ben Summers and Dr. Lok-Wong Sampson from the Department of Health and Human Services. Your slides are up. You have the floor.
Great. Thanks so much, Dr. Hopkins. I'm Ben Summers. I'm the Deputy Assistant Secretary in the Office of Planning and Evaluation at HHS. And I'm going to turn it over in a second to Dr. Sampson for the presentation, but I just want to give a little context. So our office, known as ASPE, is essentially the in-house think tank for HHS. And we've been doing a lot of work to support the Secretary and decision-making related to pandemic response, including vaccination strategies and including analyses of vaccine hesitancy, patterns of penetration of vaccination rates across the country. And in this report that you'll hear about shortly, using both the county level vaccination data, but then detailed individual level Medicare data to understand the impact of vaccination on key COVID outcomes. So I think our report complements what Dr. Scobie just presented at the ecological level with individual claims and individual analysis of Medicare beneficiaries. So I'll turn it over to Lok-Wong Sampson. She and Dr. Wafa Tarazi are our 2 analytical leads on this project.
Thank you, Ben. Good afternoon, members of the National Vaccine Advisory Committee. We are pleased to present an overview of our study, and I would just like to acknowledge the contributions from our study co-authors listed here. Next slide, please. So the purpose of this study was to identify associations between initial county-level vaccination rates in early 2021 and COVID-19 infections, hospitalizations, and deaths among Medicare fee-for-service beneficiaries. We then wanted to estimate the reduction in those infections, hospitalizations, and deaths amongst all Medicare beneficiaries associated with the first 5 months of the COVID-19 vaccine rollout. Just quickly, an overview of the methods. We examined COVID-19 outcomes using Medicare claims from January to May of 2021 in a study cohort of 25.3 million Medicare fee-for-service beneficiaries. And we then projected the results to 62.7 million total Medicare beneficiaries. Our key study predictors were looking at county level rates of vaccinations as measured by the proportion of people in the county who were fully vaccinated in 2 age groups, ages 18 to 64 and those 65 and older, using CDC's data. This was because individual level vaccination data is not available. For our model outcomes, we looked at COVID-19 infections, a hospitalization within 3 weeks of that initial diagnosis, and death within 9 weeks of that initial diagnosis. And we had access to person-level Medicare claims data, so we could include many covariates in our regression models. Next slide, please. This study used a panel study design to examine the association between the county-level vaccinations and beneficiary-level COVID-19 outcomes. To capture the risk of COVID-19 outcomes before vaccinations were available in 2020, we developed an estimation model using claims starting from September of 2020, and then we examined changes in risk as COVID-19 vaccinations rolled out from January to May of 2021. The regression model controls for beneficiary demographic characteristics and underlying comorbidities. We also controlled for local county characteristics such as population density and using the CDC's Social Vulnerability Index. We use state fixed effects to control for potential differences between states and month fixed effects to control for temporal trends unrelated to COVID-19. We had to drop Hawaii and Texas from the model as no county-level vaccination rates were available. We then estimated the reduction in COVID-19 outcomes between the model of vaccinations and then a counterfactual model where vaccination rates were set to 0 for all groups. We also examined reductions in COVID-19 outcomes by race, ethnicity, and nursing home status, and for individual states. Next slide, please. This is a summary of our key results. Overall, we found an independent association between higher county-level vaccination rates and a reduced risk of COVID-19 outcomes in Medicare beneficiaries. Table 1 shows the odds ratios for the associations in the two age groups, 18 to 64 and 65 plus, and the risk of COVID-19 infections, hospitalizations, and deaths. Odds ratios below 1 show higher levels of county-level vaccination rates were associated with a reduced risk of COVID-19 outcomes. The bolded odds ratios in the table are statistically significant. In the first column on the risk of COVID-19 infections, we find the odds ratio of 0.989 indicates a 10% increase in vaccination rates among those 65 and older was associated with an 11% decrease in COVID-19 infections. In the second and third columns of this table, on the risk of COVID-19 hospitalizations and deaths, the odds ratios of 0.989 and 0.988 indicate that a 10% increase in vaccination rates among those ages 18 to 64 was associated with an 11 to 12% decrease in COVID-19 hospitalizations and deaths. And what we think this suggests is that high vaccination rates for all adults 18 to 64 were even more protective for preventing severe outcomes in Medicare beneficiaries than just a high vaccination rate among seniors. Next slide, please. Looking now at this figure shows the estimated reductions in COVID-19 outcomes associated with county-level vaccination rates over time. The solid lines in the graph show the cumulative weekly number of COVID-19 outcomes associated with the vaccinations. The dotted line shows the counterfactual situation if vaccines were not available. We did this by modeling 0 vaccination rates. And the difference between these two lines is the number of outcomes represented by the solid and dotted lines reflects the estimated reductions in COVID-19 outcomes. So looking at the top left graph, we see that the estimated number of COVID infections and hospitalizations in our study cohort with and without vaccines. We estimated vaccinations were associated with 107,000 fewer infections, about an 18% decrease, as shown by the blue solid and dotted blue lines, and 43,000 fewer hospitalizations, about 21% decrease, shown by the brown and dotted lines. The bottom right graph with the red solid and dotted lines shows vaccinations were associated with about 18,000 fewer COVID deaths, a 22% decrease in our study population. Next, I'm going to turn to my colleague, Wafa Tarazi, to show us how our overall study findings projected to the full Medicare population in 63 million beneficiaries.
Thank you, Luke. Next slide, please. So we extrapolated the estimates of the Medicare fee-for-service study cohort to the total Medicare population, which includes 63 million beneficiaries between fee-for-service and Medicare Advantage plans. Doing that, we estimated that the vaccination between January and May 2021 was associated with 265,000 or 250,000 fewer COVID-19 infections, 107,000 fewer hospitalizations, and 39,000 fewer deaths. Compared to the counterfactual model with no vaccines available, these numbers represent an 18% reduction in infections and 21 to 22% reductions in hospitalizations and deaths. Next slide, please. This figure compares the bars to the dots by state. So what are the bars and the dots? The bars are the estimate cumulative reductions in COVID-19 infections, hospitalizations, deaths per 100,000 Medicare fee-for-service beneficiaries. The dots are the average vaccination rates. The states are ordered from highest to lowest vaccination rates. We found that reductions in COVID-19 outcomes was reduced in all states included in this study. On the left side of the figure, states with higher vaccination rates had a higher or greater reductions in COVID-19 outcomes. On the right side of the figure, reductions in these outcomes rise more dramatically, indicating that the biggest benefit of additional vaccination happened in states that started at lower vaccination rates. Next slide, please. These are results of reductions in COVID-19 deaths. Vaccination was associated with 21 to 25% reduction in COVID-19 outcomes among racial ethnic groups. The highest reductions, the highest percent reduction happened among American Indian Alaska Native Medicare beneficiaries, who had about 25% reduction compared to the 22% reduction among white Medicare beneficiaries. White beneficiaries comprised 81% of the study cohort, so they had the largest number of COVID-19 reductions. As you can see here, there were 28,000 fewer deaths among white beneficiaries. Another group that was at risk of COVID-19 outcomes are those who reside in long-term nursing home. Vaccination was associated with 5,600 fewer deaths among this group. All these numbers are extrapolated to the total Medicare population. Now back to you, Locke, to conclude and explain much more about our future research.
Thank you, Wafa. Next slide, please. So in conclusion, our study shows that the initial county-level vaccination rates were associated with significant reductions in the odds of COVID-19 outcomes. We estimated vaccines were linked to 250,000 fewer infections and 39,000 fewer deaths amongst Medicare beneficiaries in the first half of 2021. The strength of our study includes person-level data on demographics and clinical features, unlike many of the broader vaccine-related analyses. We do plan to conduct an updated analysis with data from the second half of 2021 so we can assess population-level effects with rising vaccination rates amid the Delta and Omicron surges. As part of these future analyses, we hope to refine our model to add state mitigation efforts, mobility data, vaccination rates in nursing homes, potentially assess interactions between vaccination rates and specific subgroups, and estimate the savings to Medicare from these reductions in hospitalizations. Thank you. This concludes our presentation. We'd be happy to take any questions.
Thank you very much. Good presentations from all of you. If any of the members on the call want to raise a question or make a comment, you can either raise your hand or send me a note in the chat. Thank you. Looks like John Dunn has a question. John, go ahead.
Yeah, I still have trouble figuring out how to raise my hand. Thank you both for, thank you all rather for these presentations. These are really interesting. I love work like this. especially in light of the earlier discussions that and presentations that talked about vaccine confidence and our increasing knowledge that the problems with confidence tend to vary from group to group and from vaccine to vaccine. What I particularly love about this sort of thing is that finding out, doing research that's intended to find out that there are specific subsets where maybe targeting those groups and making sure that we can maximize vaccine rates in them will have a bigger bang for the buck than in others, is going to be very helpful when figuring out how to direct our limited resources and limited ability to craft messaging that's suitable for everybody. That by way was just a comment. It's a practical question. Is where and how this information from both presentations, when and where does this get published? That is, where can we see it so we can actually digest it and think about how to put it to practical use?
So we can paste in the link. This is a published report on the ASPE website, and HHS also did an aggressive media outreach effort around this report, which included some national and local TV coverage and news coverage around it. So this is definitely, we think getting this information out, dissemination is an equally important part here, in addition to the methodological rigor.
Fantastic, thank you. And keep going. I look forward to much more like this. I think that this is where a lot of vaccine related work needs to go in the future. Thank you very much.
Dr. Mullen, you have your hand up next.
Thanks. Those were clear and encouraging presentations. I work in Texas, so I listen to what you say and wonder, how can we as NVAC members help get data in our state? That might not be a question for you to answer right now. But the other one that I have relates to the completeness of your data by race and ethnicity. Did you have those data on everyone because they were Medicare beneficiaries, or were there still lapses across the states?
I think it's fairly complete for the Medicare data, and there are also imputation methods that are used to improve the data quality. This may not be the case for other populations.
Our next question is from Jeff Dushan.
Thank you. Little trouble starting the video, so you're just going to have my profile for this, but really appreciate this presentation. Also find it to be extremely valuable on a number of fronts. I'm hoping that you can continue this type of analysis beyond the second quarter of 2021 to help us understand the durability of the benefits over time, whether we continue to accrue benefit over time, given, however, the national vaccine policy on doses and administering boosters evolves. And I was wondering if you have anything that you can tell us about any differential impact of quote unquote fully vaccinated versus vaccinated and boosted.
This would be a good question for Heather, since we don't have access to the boosters versus fully vaccinated in our Medicare data set.
Hi, Jeff. So the question is about how do people without booster doses versus booster doses compare?
In this analysis, yeah, could that be differentiated? It sounds like no, and I guess it gets at the confusion between, the definition of fully protected, fully vaccinated. We know that boosted really is necessary to be fully protected. So a couple of things, related to this, both the desire to understand the impact of boosters, but also the implications around these definitions, which, fully vaccinated not being fully protected, and needing to resolve that somehow.
So the language, I agree, has become quite complex. The language CDC uses now is up to date to describe people who have received all of the doses they should have received. Fully vaccinated still applies to the primary series, and there's a lot of implications for why that's the case. But that's still the way it reads on the website. And we did evaluate in this study the with and without booster doses, and there's a considerable difference between the two, and including during Omicron. And we'll continue publishing that on the CDC COVID data tracker. So I think we were showing, for example, during the month of December for Omicron, that people who had a booster dose were 5 times lower risk of infection compared to unvaccinated people, compared to 3 times if you didn't have a booster dose. So there is a benefit. There's been with Omicron, there has been a hit to the vaccine effectiveness for both people with and without booster doses, but the vaccines still appear to be holding up well against hospitalization. That's come out in other publications, and we'll be publishing soon on the website the first data that we have during the Omicron period for deaths. And so you can look forward to that as well.
Yeah, thank you for those comments. It reminds me of the evolving discussion around what is the goal of the national COVID-19 vaccination program. And, due to great enthusiasm, initially became implicitly, if not explicitly, to prevent infections. But over time, I think people have come to realize that's perhaps not very realistic, and whether we need to more clearly and formally articulate what the goals of the program are, and whether that would be useful.
I think it's a great comment, especially during this Omicron period, where the severity of the variant is lower than previous variants. Thanks.
I want to thank the members of our last panel, both from CDC and from HHS. We're going to now turn to our next presentation, Prohibiting Discrimination in COVID-19 Vaccination Programs. We're going to hear from Lisa Pino, the Director of the Office of Civil Rights at HHS. She's going to discuss new guidance to boost accessibility and equity in COVID-19 vaccine programs. Lisa, you have the floor.
Thank you so much. Good afternoon, everyone. It's such an honor to join all of you. I know that you've had a jam-packed, fun-filled day. It's a privilege to be with all of you, and an invitation from the Director of the National Vaccine Program, Admiral Levine, and VAC Chair, Dr. Hopkins. It's wonderful, and I have visited the UAMS campus in Arkansas, and it's gorgeous. And all members, welcome. I know it's late afternoon. It's a hard time to get your attention, but I'll do my best. So hello, everyone. I am Lisa Pino, the Director for the Office of Civil Rights at HHS. I am going to present as best I can and keep everyone on time on our most recent, latest and greatest December guidance entitled Title VI guidance to ensure equity in the distribution of COVID-19 vaccines. I am 4 months in the job. Prior to this role at HHS, I was the Executive Deputy Commissioner for the state of New York during COVID. And prior to that, I'm an attorney by training, not a physician, such as all of you. And prior to that, I served in the Obama administration 2 terms. For the first term, I served at USDA. In agriculture, I was the administrator for the SNAP program, and I also worked in the civil rights shop. And then second term, I worked at Homeland Security of all places, but DHS actually has a health affairs portfolio, and my colleagues and I worked directly for the Secretary, what was then the Ebola and Zika response with CBP and TSA. So next slide, why don't we go ahead and get started? So as mentioned, late December, we issued the guidance. The guidance was designed to ensure that entities covered by civil rights laws understand their obligations under Title VI of the Civil Rights Act of 1964 and Section 1557 of the Affordable Care Act, the ACA. So these two sets of laws are the foundational legislation from which we ensure that all COVID vaccinations are served with equity and protects from discrimination. Next slide. The guidance was built upon resources that we learned of in April of last year in 21, and Title VI foundationally prohibits discrimination based on race, color, national origin, in federally funded programs. And Section 1557, of course, prohibits discrimination against race, color, national origin, age, disability, and sex discrimination in certain health programs and activities. And why are these laws so important? So for the Office of Civil Rights, they are our tenets, they are the principles by which we ensure that federally assisted healthcare providers and systems do everything they can, and they have to comply to ensure fair, equitable access to vaccines and boosters. And recipients of federally funded assistance in state and local agencies, hospital and healthcare providers must all adhere and comply to these civil rights tenets, and that's why the work that all of you are doing as members of the NVAC is so important. Next slide, please. Nevertheless, as you all will know, that despite the expansion of vaccine availability and even the work that we're doing in our oversight capacity, disparities, of course, still exist. And if anything, they have been magnified under COVID. So, if you have systemic discrimination, decades in the making, this is all contributed through that lens of the social determinants of health, how we have these long-standing healthcare disparities. And nevertheless, these disparities have influenced the rate of COVID-19 infections, hospital admissions, and death rates, particularly among people of color. Next slide. So it's critical that vaccine access be accessible and free of barriers, and policies and practices that have a discriminatory effect must be eliminated unless a recipient can show that they were necessary to achieve a legitimate non-discriminatory objective. But under federal civil rights laws, even if there is such a reason, the practice cannot continue if there are options that show another legal alternative that would achieve the same result, the same objectives, but without any discrimination on the basis of race, color, national origin, such as language discrimination. Next slide, please. So OCR, our Office of Civil Rights, we are aware of stories in the media, and we have received complaints, alleging, for instance, I'll walk you through some examples, but where covered providers are not meeting their legal obligations to make information provided in vaccine programs accessible. So for one, if you have a city-run vaccine site in a neighborhood where there are predominantly, immigrants who speak a particular language, but maybe there is no signage in that language, even though the vaccine supply is plentiful, or there are no intake questions. So, perhaps folks in the neighborhood go into the vaccine site, but there aren't not only translated materials, those translations lack cultural competence, and the folks there aren't able to feel welcomed and be able to obtain the information that they need. That would be one example where there's discriminatory access. In another state we've seen where non-English speakers were handed COVID-19 vaccination cards without information about how to receive translation services, what they should do after the vaccination to take care of themselves, when to be concerned about side effects, etc. And, sometimes we've also seen particular communities of color where they weren't able to make vaccine appointments, which early on in the pandemic was so challenging due to a lack of interpreters and hospital call centers. So we received complaints regarding deficiencies in programs across the country that have inhibited access to vaccinations for people, for instance, in these instances where they have limited English proficiency, and under the law, these providers do have a legal obligation under Title VI and Section 1557 to make sure that there's equitable access. Next slide. So, as we've seen for these illustrations of scenarios where policies or practices, even if they're unintended that way, they do have a discriminatory impact, and they serve as discriminatory barriers to people who are trying to access vaccines or boosters. So, if a health department sets up a clinic that prioritizes vaccines to a certain population without a legitimate non-discriminatory reason, that would be yet another instance where these barriers are occurring, and it would be an actual violation of the federal civil rights laws if there's no alternative practice that's the only exclusion where discrimination would not apply, but they would have to, again, achieve the same objective result without discrimination on the basis of race, color, national origin. In another example, we've seen a vaccine distribution program that was designed to be distributed solely by pharmacies as a requirement that the vaccination appointment registration must be conducted online. Many communities of color are located in pharmacy deserts where there are few chain drugstores. And then in addition to that, we know that the digital divide is real. So having that lack of access through mainstream pharmacies, drugstores, on top of insufficient access to affordable internet for the digital divide, these are real life examples of how communities of color, may not have the access that they deserve and need for vaccinations. Next slide. So as I'm sure you're all aware, what has the administration done in response to this? Well, just a few days within taking office, President Biden issued Executive Order 13995, which I'm sure you're familiar with, ensuring an equitable pandemic response and recovery that has very much served as a framework for the administration to be able to build health equity during this kind of crisis. It really is intended, the order, to address the disproportionate and severe impact of COVID-19 on communities of color and other underserved populations. Racial justice and building equity is one of the 4 central tenets of the administration's values, and it's something that the present administration has worked hard to bridge. So the order expressly requires federal agencies such as HHS to assess pandemic response plans and policies through that civil rights lens. That's our obligation. And to determine whether it's PPE, tests, vaccines, therapeutics, whatever other resources, whatever the means to help provide that assistance to communities, that it will be allocated equitably. And again, through the lens of civil rights. The EO also mandates agencies to strengthen enforcement of anti-discrimination requirements pertaining to the availability of and access to COVID-19 care and treatment. And the order reinforces our core mission with the Office of Civil Rights at HHS of, again, enforcing Title VI and Section 1557 are central tenets for civil rights law protections for the pandemic. And it provides a specific mandate for us to ensure that equal access is available throughout the COVID-19 vaccination programs. Next slide, please. In addition to reminding entities of their obligations under Title VI and Section 1557, our guidance for the Civil Rights Office, we offer a lot of best practices that we hope are practical and helpful to boost accessibility and equity for vaccine programs. So for instance, we review policies, we help manage data, we partner with organizations, we work hard, with providers to eliminate language barriers. We understand immigration concerns like public charge and fear and distrust of federal agencies. We conduct outreach, we engage with partners, and we also work to locate vaccination sites in historically underserved communities. Next slide, please. In some, the Office of Civil Rights, we are a law enforcement agency. And so, the way that we're able to exercise our tool and make sure that the law is served is we enforce, and we have a robust enforcement program. We have played a particular role in ensuring that equity is at the center of the department's enforcement and compliance across the country. And, sometimes we help with information provided by flyers or online information portals, even in person on the ground at vaccine distribution sites. But, we ensure that there's a legal obligation that all COVID-19 vaccination programs must adhere to. They must be accessible. They must be free of discriminatory barriers that limit a community's ability to receive vaccinations, including boosters. Next slide. I just noticed that we were on time and I don't want to go beyond. So we know how important the work that you do through the NVAC and as members. We know how important it is to make sure that vaccines are accessible to anyone that wants one, and how that reflection, sadly, of the health disparities that still exist, our ability to help bridge those gaps and make sure that, no matter your zip code, no matter your background, if you're eligible and you're ready to get vaccinated, that there's one in reach for you. We have more information on our website. I'm happy to provide to the chair and the committee any other information, but you can find more information that might be useful to you through these links. And we're at 4:46, Dr. Hopkins, so I'm happy to take a question, or if you want to continue to adhere to the agenda, either works for me. But thank you so much for the opportunity to join you, and thank you to all of you for the important work that you do at this time.
Thank you, Lisa. We appreciate your presentation. What I'm going to ask is if anybody has any questions or comments, if they put those in the chat, we will get those to you, and we'll record those in our minutes for the meeting also, so that we can stay on time. Thank you. Thank you for your time and presentation. Our next panel is toward a vaccinated workforce. In this last panel of the day, we'll hear presentations about vaccinating the workforce. First up will be Dr. Emily G. from the Centers for American Progress. Then we'll hear from Lorraine Martin from the National Safety Council, and then Michelle Hood from the American Hospital Association. See if we could get Dr. G's slides up, please. Dr. G, you have the floor.
Thank you. Good afternoon. Thank you so much for inviting me here today to speak about workforce vaccination. I want to discuss the crucial role that employers play in not only promoting safer workplaces through vaccination, but also in raising community vaccination rates and addressing challenges to vaccination, including access and vaccine hesitancy. I will also speak about how employer vaccine requirements, as well as state, federal, and local workplace vaccine rules, can effectively increase vaccination rates and protect workers from COVID-19. Next slide, please. Employers can accelerate vaccination in a variety of ways, and none of these approaches that I list here is mutually exclusive. First is improving access. Early in the U.S. vaccination campaign, we saw many large employers arranging for on-site vaccination clinics, and others arranging for transportation to off-site vaccination locations. Paid time off for vaccination and recovery from its side effects for both workers and dependents can also support community vaccination efforts. In a census poll last December, about half of the unvaccinated adults cited concerns about side effects as a reason they did not get vaccinated, which means that continuing to provide paid leave for vaccination remains important. Second, employers can help inform and empower employees by providing educational materials at work and supporting awareness campaigns for the broader community. And third, employers can create incentives such as monetary rewards for workers or perks for customers, or even requirements to get in the door for restaurants and dining to encourage vaccination. And lastly, employers can require vaccination for workers and for customers, and I'll come back to that later. Regardless of the exact approach, employers can make vaccination requirements and incentives more equitable by combining them with efforts to improve workers' access to vaccines and ensure that workers have good information about vaccines from trusted messengers. Next slide, please. Workplace incentives for COVID-19 vaccination make sense both from the perspective of the firm and for public health. For employers and employees, vaccination is crucial to worker safety because it dramatically reduces the risk of infection with COVID-19. It also reduces the risk of transmission to customers and patients, and in educational and childcare settings to students and children who may not yet be vaccine eligible. By reducing community spread and workforce disruption, vaccination of the population also supports the recovery of economic activity throughout our country. While some employers have voluntarily adopted vaccine requirements, there's also a strong public health rationale to apply requirements across industries or to all employers. Vaccine requirements raise population-level vaccine rates, offering stronger protection not only to the vaccinated, but also those who remain unvaccinated or who may be immunocompromised. Broad-based vaccine requirements also level the playing field economically, ensuring that firms that do the right thing for public health aren't disadvantaged in attracting customers or retaining their own workers. Next slide, please. Next, I want to talk about bolstering the current U.S. vaccination efforts. With over 540 million doses administered, about 2/3 of the population fully vaccinated, according to the current definition, and over 40% of the population boosted, the U.S. has made tremendous progress. Yet we would all be safer and the economic recovery could be even stronger at higher levels of vaccination. This is important, but won't be easy. According to the most recent survey data, about 1/3 of unvaccinated adults express openness to getting vaccinated. But a sizable share of workers remain unvaccinated in many industries, including some that provide essential goods and services. For example, 22% of workers were not fully vaccinated at hospitals as of last December. 22% of childcare workers were unvaccinated as of early last summer, and a majority of workers in the agricultural industry remain unvaccinated now. Next slide. While vaccination requirements are appropriate in all workplaces, I want to highlight 4 settings in which vaccination mandates are particularly important. First, vaccination of healthcare providers is crucial for the safety of patients and healthcare workers, and for the continued function of our very strained healthcare system, which is already experiencing shortages of workers, and many places is overwhelmed by patients in places experiencing surges. I applaud the Biden administration for the CMS rule that requires healthcare providers and suppliers to vaccinate all eligible staff as a condition for participation in Medicare and Medicaid. The second category is schools and childcare. Educator and staff vaccination is essential to protect unvaccinated children, minimize transmission, and allow students to safely benefit from in-person learning. Among the youngest age range that's vaccine eligible, about 1/3 have not received any dose. Third, workplaces prone to outbreaks should mandate vaccination. This includes high-density facilities where social distancing isn't possible, like meatpacking and poultry processing plants, and congregate settings such as group homes, carceral settings, and domestic violence shelters. And then fourth, we should prioritize the health of first responders and other essential workers by requiring vaccination. This includes those with critical functions or those who are at high risk of close contact with unvaccinated individuals, including emergency responders. Next slide, please. Looking to survey data, we see that employers are split on whether mandates can be a help or a hindrance to employee retention. There's wide variation across industries driven by employer choices as well as state and local requirements. While some employers and employees have voiced opposition ahead of mandate implementation, in an employer survey by Willis Towers Watson, 71% of respondents with vaccine mandates in place said they saw no change in turnover, with only 4% experiencing significant increases in turnover. It's also important to remember that some workers may be attracted to workplaces with mandates. While 1 in 3 are concerned about employees leaving the organization due to vaccine mandates, about half believe that mandates could help recruit and retain employees. However, in the absence of the OSHA emergency temporary standard that would have applied to large employers, it's unlikely that most workplaces will have mandates unless the agency can put in place other, perhaps more narrowly tailored requirements. In one poll of 500 firms, 50% had a requirement or were planning to require, 9% were considering it, and 42% were not considering it. Next slide, please. Data points from firms and industries that are subject to vaccine requirements show us that mandates do work. For example, 90% of full-time employees at Fox Corporation were fully vaccinated by last September. In New York State, 92% of healthcare workers had at least one shot by the state's deadline. More than 96% of Tyson Foods' active workforce was vaccinated before its mandate deadline. And more recently, United Airlines reported in January that weekly employee deaths had dropped to 0 for several weeks, which wasn't the case earlier in the pandemic, which it attributed to its vaccine mandate. As the US attempts to get more of the population up to date on COVID-19 vaccinations, I hope that individual firms as well as policymakers will consider workplace policies as a mechanism for improving public health and supporting pandemic recovery. Thank you.
Thank you very much for your presentation, Dr. G. Next presenter will be Lorraine Martin from the National Safety Council. Ms. Martin, your slides are up. You have the floor.
Yeah, thank you all for having us here today. If you don't know what the National Safety Council is, I'll just give you really quick. We are America's leading nonprofit safety advocate and have been in place for over 100 years. We're a mission-based organization, and our primary focus is to eliminate the leading causes of preventable death and injury in the workplace, on the roadway, and specifically looking at some issues having to do with impairment. So the safety of workers is our job. And we not only look to keep workers safe, but also give them the tools and resources so that they can bring that home to their communities and their families and live their fullest lives. So clearly, as COVID-19 became the biggest workplace safety hazard in the last couple of years of a generation, it became a big focus for the National Safety Council. It is a leading cause of death in our nation, and certainly workplaces that are part of our nation's fabric have experienced that as well. The one silver lining is it means that we've been really focused on worker safety, and I hope some of that is a dividend that will continue past the pandemic, as we all understand that workers depend on their employers to keep them safe. I come to you today not only as the CEO and president of the National Safety Council and the representative of our 15,000 members, which are all workplaces around the U.S., but also I lead an organization with human beings that I need to keep safe. And we have been remote for almost 100 weeks. And my focus every time I've made a decision around what policies to have in place for the council, knowing that I will be an example for other businesses, was to always make sure that I kept my colleagues safe from contracting the virus, if at all possible. And as we heard before, also ensuring vaccination to ensure that the impact of the virus, should they catch it, be less. This has been a really challenging road for many companies to navigate, but I will tell you, employers do know that it is their responsibility to keep the health and safety of their workers intact as they're doing their job, and COVID is really no different. If vaccinations can't be required now, as we just heard from Emily, because the ETS was stayed for workplaces of 100 employees or more, we are still encouraging workplaces to have risk-based approaches, which I think is what Emily just outlined there, that focus on high-risk environments where COVID or an infectious disease, airborne infectious disease, will be of highest risk. And we encourage, as Emily said, encouragements, incentives, making it easy, all of the tools that she talked about, and will continue to be helping companies navigate that. If there is any good news, and if you can go to my next chart there, it is that over the last couple years, industry itself, businesses, have become a trusted institution. In some cases, unfortunately, more trusted than the media, more trusted than NGOs or the government. And as a result, there is a responsibility then for industry leaders to use that trust to help their employees navigate this very complex and sometimes, as we know, emotional journey of understanding how to keep yourself safe. The Edelman Trust Barometer just came out with a new report here regarding during the coronavirus time in the U.S. and revealed that industry is still a trusted voice for employers to get their best information and understanding that the employees had their best intent and their best case in hand. As I said, that means employers do have a role. They can make a difference, and they have a responsibility to do so and to be a source of truth and guidance. We have roughly 157 million Americans in a workplace. It is a great place for us to reach folks with safety-related and health-related information. And that goes the full gamut of, as we just heard from Emily, having to do with vaccinations, having to do with other kinds of countermeasures that they can use not only at work, but as they go back to their communities and their homes. We have really sharpened, if you can go to my next chart, our focus on workplace safety as part of the pandemic and as it unfolded. We created something called SAFER, and it was called Safe Actions for Employee Return. We created the name Return with some hopefulness, back literally in about the April timeframe, just after the pandemic began, knowing that that's what companies need to do. They need to get their employees back to work. They needed to get them back to being in the work environments that could be safe. And in forming this coalition, we brought together companies from around the world, literally, leveraging some companies that had been in China and France and Italy when the pandemic was starting there before it hit here in the US, and enabled us to get the best practices, the playbooks. Literally, major Fortune 100 companies would take, their cover, their logo off of their COVID playbook, give it to us to make it, sort of white paged, and then provide it to anybody who needed it. And at that time, it was really important to get those best practices and make sure that we could get that out to companies, especially small and mid-size, as quickly as possible. We also very much supported vaccine requirements, and those can be of all sorts, including all the way to a mandate. We were disappointed to see the stay on the emergency temporary standard. We called for an emergency temporary standard back in about the May timeframe of 2020, because we do know that OSHA and CDC can give us great guidance of how to keep people safe in the workplace. And for many workplaces, they needed that requirement. They needed that guideline to tell them how to do this. Regardless of that, as I've said, it's really important that workplaces stay diligent here. We are a place that we can use these tools, and again, to keep them safe at work, and then as they leave our doors, to go back into their communities. Because employer action matters, and if you can go to my next chart, we also have some data here to show you from the Kaiser family, and I know Emily showed you some data that kind of bookends with this. 73% of workers who were encouraged by their employer to get a COVID vaccine received at least one shot, and that's in compared to workplaces where you didn't have that leadership from the company was only at 41%. That's a big difference. That voice mattered. We have resources available for companies on the Health Action Alliance, the HHA consortium that came together just to help workplaces here. And it was really important for us to provide materials for workplaces to have this voice, to navigate it carefully. And in many cases, we created materials that could enable you to talk to certain, whether it's certain industries, certain demographics, certain heritage, language barriers, those kinds of things. And those resources became extremely important. And you can see here, the employer voice does matter. You can go to my next chart. It's also very clear that employer vaccine requirements worked. And Emily quoted United. I have the same note here. They got to 96%. And then I think their approach was for most of the employees who couldn't find a way to get vaccinated, they were put on unpaid leave. A lot of folks use different techniques of saying what happens if you don't. You can see here some incredible progress. The National Safety Council also got to 100%. I did have less than 1% of my staff choose to not stay with us as a result of our vaccine requirement. But that's very small as much of the data has been reported, and it made a huge impact for the people that I need to keep safe. And you can see here across some of these other companies, the great uptake of vaccine percentages that occurred. According to another survey that we did very recently, nearly 95% of workers at a location with an employee vaccine requirement are vaccinated now, compared to just 75% in general with workplaces that did not have a requirement. And I love how United and Scott Kirby really positioned this, because as we heard, I think from another speaker here today, the messaging is really important. Vaccines were, yes, about making sure that folks might not have caught the disease to begin with, but as it progressed and we got to Omicron and other understandings, it was also very important to say that you weren't going to die or be seriously impacted by it if you did get the virus. And Scott's message about not having folks die or be hospitalized on the other side of this, although they did have flight attendants and others who were infected by the virus and couldn't come to work, he was very great in understanding and messaging what it really was all about, and it was very, very impactful. And his voice, truthfully, not only helped his company, I've talked to other CEOs of companies who said that his voice and his messaging enabled them to lean in and go further. So again, employer voices matter. They have helped us save lives during this pandemic. The Health Action Alliance that I mentioned, I would encourage the group here, if there's any materials that you're looking for of how workplaces need to talk to this issue. We keep updating that material. It's funded also by the Ad Council, the CDC Foundation, and several other large foundations that have helped us with providing guidance to employers during this time. I encourage you to look at the website and see if there's anything that might be of use. And I'm really proud, as I said before, that we did get to 100%. But what's much more important, in addition to my staff, is to make sure that we modeled what we knew that employers could do and the impact that it could make, not only for the folks that come in their doors or do their work, but for the communities that they live in. You can go to my next chart. Additional actions, and I'm sorry, it's a little small here, but employers who get it can take action really beyond even requiring vaccines. And we heard a couple in Emily's pitch about providing resources, offering paid time off for the vaccine and recovery, hosting vaccine clinics, and quite a bit more. And you can see some of them on here, but those are really important things that we still need to be doing, given that we've seen that the vaccine uptake still is not where we need it to be across our nation. Next chart. So looking ahead just a little bit of where employers can play now. It's really important that we understand that COVID will be with us for some time. And so we need to make sure that we are still putting in place the right kind of workplace practices that are relevant for the risks that you face in that environment. Vaccine requirements for in-person events is something that you can also do, especially if a portion of your employees are able to work from home. And then just reducing barriers to getting a vaccine or taking time off if someone's not feeling well. Those are all things companies have in their pockets and need to continue to use. I would tell you one that we often harp on is ventilation and ensuring that buildings that folks are operating in have upgraded ventilation. It's not one that we often hear about sort of in the general public because we're talking about masks and 6 feet and vaccination, but ventilation is really, really critical, especially in those environments where you have humans that are close to each other in doing their operations. And then if you can go to my next chart and then I'll close. Business engagement is really critical. And since the beginning of the National Safety Council, we've seen employers get ahead even of being required to do things in the safety and health world. The council was formed because industry said people should not have to be harmed to earn their living. And it's important for us to know that we have to continue to lead in and use that trusted role that industry has at this point in time in our history, and use our voice and use the actions so that we can make sure employees have trusted information so that they can both empower themselves and then educate themselves and those around you. So I'll just close there with my next chart and just say thank you. It's really important for us to partner with all of the organizations that are advising our government of how to navigate this, and just know that employers are part of the equation, and we look forward to continuing these conversations so we can save lives in the workplace, as we say, to any place. Thank you.
Thank you, Ms. Martin. Very helpful presentation. Our next presenter is Michelle Hood from the American Hospital Association. Ms. Hood, your slides are up. You have the floor.
Thank you so much. So good afternoon, everyone. I'm glad to be part of this important discussion today. Let me start this part of our discussion by describing a sample of the work that the American Hospital Association has been undertaking to contribute to the effort of getting America vaccinated. We've been in this fight with all of our clinicians and our government partners for over 2 years now, and every day kind of brings a new chapter to the effort. But I'm very pleased to be with you today to share some of the work that we're doing in the area of vaccination. Next slide, please. So our work has been multi-channel, and I'm going to try to describe some of that with you today. Certainly, we have provided a number of resources for our clinicians all along the journey. We understand that the clinicians remain trusted resources for individuals and communities. We provide print resources to our physicians and other clinicians about the different vaccines. We have been providing opportunities for dialogue with experts like Dr. Bashir Shakir there in the bottom right-hand corner of the White House response team on vaccination. We've been contributing to print material that goes out to our members. We have 5,000 plus hospitals and health systems that are part of our membership. So we represent a very high percentage of the clinical resources within the U.S. at this point in time. And we have been keeping them up to date to the degree that we can on where the science is leading us on all issues related to vaccination. Next slide, please. We've also been working with our 5,000 plus hospital members to reach out to their communities, providing them with resources in order to provide resources to community voices that are trusted, whether they be clergy or community leaders of any type, the ability to help connect hospitals and businesses who want to create pop-up vaccination sites as part of their efforts to increase COVID-19 vaccinations, anything and everything that we can do to increase awareness and promote the realities of the current situation, to demystify vaccination to the degree possible, to combat some of the misinformation and disinformation around that. And I'll speak more about that here in a moment. Next slide, please. We've also been working with our health systems and hospitals around what's working, because what works in New York City doesn't necessarily work in Indianapolis, Indiana, or in Iowa City, Iowa. And we have a very vast network of communication capabilities to reach into our membership and share with them what seems to be working best in other spots so that they can amplify, replicate, and connect resources in order to increase vaccination in their own communities. In addition, we've been working with the White House response team about standardized approaches to vaccination at various touch points in the care continuum. So we started with the emergency departments so that patients coming into the ED for trauma or emergency needs would also be offered the opportunity to be vaccinated if they weren't. Then we moved into vaccination at discharge, educating patients and their families about the safety of the vaccine and encouraging vaccination as part of the discharge protocol, and on through all of the places where we have the opportunity to interact with our patients on a day-to-day basis. Next slide, please. But, we still have problems. And I think several of our speakers today have talked about the fact that while things seem to be on the downward slope, which is great at this point, we've seen the downward slope before, and we don't know what's necessarily around the corner. And our healthcare workers on the front lines, I will say, are exhausted. They're particularly overwhelmed with the number of patients who are coming into our hospitals and unfortunately not leaving our hospitals and regretting the fact that they were not vaccinated. And so we have been working very diligently to partner with others who can help us carry the message, particularly to those underserved communities. So we have a partnership and a relationship with the National Urban League to reach out to the African American population, with Unidose US to reach out to the Hispanic American population. We've worked to have trusted voices in those communities who have distrust in our American institutions and unfortunately our American healthcare provider institutions, to carry this message as we go forward. Next slide, please. We have a special relationship with the CDC and have enjoyed that for many, many years, even pre-pandemic at the American Hospital Association. But we've leveraged that relationship together with the CDC to look for opportunities to be particularly helpful in this issue of trying to increase and optimize the number of Americans vaccinated. So I'll describe a little bit about that effort here in the next couple slides. Next, please. We have a multi-year CDC grant where we meet on a regular basis several times a month around the dimensions that you see on this slide: building trust, which seems to be a continuous problem and challenge for us going forward; empowering our healthcare workers who have a special role to play in talking to their families, their patients, their communities about COVID and all the issues of keeping safe during this pandemic. And then how do we creatively engage communities in ways that are reflective and responsive to the way that particular community wants to hear about things like vaccination and science and health. Next slide, please. We are using the 4 channels or elements here that you see on this slide. I think it's somewhat not duplicative, but complementary to what we've heard from other speakers about the fact that you kind of have to go at this from multiple vectors in order to reach the people that we're trying to reach. So looking at trusted messengers, looking at digital, looking at our mainstream media and other media channels, and then the personal touch around community outreach. So I'll give you a few examples of that in the next slides. Next, please. So on the trusted messengers, this has been particularly successful for us. We've been able to recruit our frontline providers across the country, 43 official ambassadors, but many, many others who have been able to carry the messages through their community radio spots, their community newspapers. We've been able to give them talking points, the latest science, the most recent information on guidance, the best practices that we're picking up from across the country, and having them carry those messages into their communities, totally responsive to the resonance of the individuals within their communities who want to hear from people that they know. So this has been really, really successful, and we're still working on this on a week-to-week basis. Next slide, please. In addition, we've recognized that different communities or ages, generational segments of our population get their news differently. And so we've flooded the zone, if you will, on digital strategies. We've had individuals from the clinical community contribute to the MyWhy videos, doing their own video clips, posting those on YouTube and other social media. Millions, as you can see there, of views, capitalizing on the fact that many of our hospital systems and hospitals individually have great social media networks that we can plug into and share these messages. Next slide, please. In addition, you might have seen many of our multi-channel media messages. We've been running these PSAs, op-eds, and other social media opportunities intermittently, mixing it up, trying to make sure that we stay creative and share information on a real-time basis. Lots of feedback from communities about the impact of that, and we'll continue to do that as we continue to work on getting the country vaccinated. Next, please. In addition, as I said, community outreach, lots of community events, lots of small group meetings, preparing all of those speakers that are out there across the U.S. with case studies, with best practices, with video, with collateral material so that they can share this information with their communities. In addition, webinars, tons of webinars over the last 2 years, targeting different audiences, our own clinicians, so they become educated and aware of the latest information so that they can be spokespersons, but then out into the general public as well. Next, please. Further examples of our community outreach, I'll point you to the AHA.org/vaccine-stories. You can go there and see some of the best practices, things that have worked tremendously well. And I'll reiterate again, what works in Chicago and LA, not necessarily working in our, our smaller communities. So we try to provide a diversity of materials for our spokespeople to have available to them, to have leave behinds and so forth, to help businesses and communities reach their vaccination targets. Next. We're also doing some research into why we have vaccine hesitancy. That has helped us kind of craft our message for those that have been less ready to step forward and be vaccinated. And we hope as we refine this research going forward that it will help us in future public health emergencies as well. But there is definitely not a one-size-fits-all message for the public. We really need to target our messages to the reasons why there might be hesitancy. A couple more slides and I'll be done. And one next is about data and the fact that we continue to collect a lot of data about vaccination rates and vaccine deserts. This is real-time data collection that should help us, again, in future situations, but also to analyze perhaps why some of the approaches that we've used have not been as effective as we would have hoped in the past, and help us to refine those going forward. And then my last slide is really to point out that we've been working in partnership with the American Nurses Association, the American Medical Association, and many others I mentioned before, Unidos US and the National Urban League. Anyone who has the same interests as ours about vaccinating the public and our own workforces has been welcome to the table. So look forward to our conversation in the Q&A.
Thank you very much, Ms. Hood. I want to thank all three of the members of this panel. Jeff Dushin, you put a couple of questions into the chat. Do you want to start our conversation, please?
Okay, thanks. Let me scroll back. Let's see. Oh, yeah. So the first question is, and thank you for these presentations. They're excellent, and I think they really are impactful at the local level as we work, very closely with our community partners and businesses. With respect to the worker mandates, this is related to a question I asked earlier about our evolving understanding of the benefits of these vaccines currently in preventing infection and transmission versus severe disease. And since, initially, we thought these vaccines were much more effective in preventing infection and transmission, but we subsequently understand that their greatest benefit is in preventing severe disease, hospitalization, and death. I'm wondering how that sort of influences the rationale for the workplace and the employers in considering whether or not to implement mandatory vaccination policies. Same for policymakers.
I can start with that. It does make it more complex because you're dealing with kind of two different messages. One, I want to keep you safe from getting infected and passing it along, and two, from if you do, having it be something that's going to be devastating for you. So I do think it complicates the message, but it's really important, as we saw United CEO, to dig in and then pivot to the rationale and the commitment of employers to make sure that their employees, even if they do get ill, they're going to be with them on the other side of that. And really, honing that message is really important. And I think we've missed that actually in the last couple of weeks as the ETS was stayed, and we all realize that this infection is fairly prevalent now in our communities. So I do think it's really important that leaders learn how to augment their message, and I'm not sure we're doing that very well right now.
I would add that, although there were more breakthrough infections with Omicron, we also saw the hugely disruptive potential for rapidly spreading variant, even more so than Delta, to have businesses end up with not enough staff to keep open a restaurant or keep open a school, and so even what might be a relatively mild variant, either very mild by nature or because of vaccination, has the potential to have knock-on effects for transit and for childcare and for just basic operations of businesses. So I think getting vaccinated is not only a matter of protecting ourselves today, but also preparedness for whatever variants might come ahead.
Thank you.
So just anecdotally, we had some very successful collaborations between my institution and some local businesses to do some question and answer with employees, to provide some education around vaccines, and then followed up with actually on-site vaccination clinics to help improve their immunization rates. And these were not healthcare industries. One was a retail, one was a manufacturer. And so having those collaborations across communities between business, community itself, and healthcare, I think is really important for getting confidence, getting acceptance, and for protecting our populations. Any other questions or comments from those on the call? Dr. Mullen, I see your hand up.
Thanks. Yep, great presentations again. And I agree with everyone's comments just now. We're still in flu season, and before we know it, we'll be back into another one. And I keep thinking about how discussion of COVID vaccine has framed the public's thinking about vaccines in general, mandates, and the need to even continue to get our healthcare workforce vaccinated against seasonal influenza. With a lot of people who say, well, I got the vaccine and I got the flu anyway. Well, I got COVID vaccine, I got COVID anyway. And so is there a way to keep these messages that we're refining and broaden them so that we're not just talking about COVID and maybe help move people forward, and rather than being stuck around some of these workplace protections?
Yeah, so I'll be glad to start. So first of all, our members have been steadfast about the flu vaccine mandate for many years. And I think probably at this point, the latest information is about a little north of 50% of hospitals across the country are mandating COVID vaccine at this point. I think it would have, it stalled when the CMS rules came out, and the fact that CMS was going to take over the mandate, so the individual hospitals did not feel the need to necessarily mandate them, that practice within their organizations. They're required by the CMS requirement. And so as that gets implemented over the months ahead, and surveys begin to take into consideration the percentage of employees that are vaccinated within hospitals and healthcare systems, we will continue to see administration and clinical leadership stand behind that kind of expectation. So I don't think that we're going to see an erosion of either the requirements around flu or the future requirements around this virus and whatever might come next.
Yeah, and if I could just comment for workplaces that aren't healthcare, flu vaccine clinics have been something over the last few years that have been very, very common and prevalent. And they've all been voluntary for the most part that I know of outside of the healthcare community. I don't know what the uptake rate is on that, but I'm sure it's not anywhere near what we're seeing for some of even COVID non-required communities. So I think there's a lot of work to do there. I know we've talked to OSHA about potentially doing a standard for infectious disease in workplaces, and that getting ahead of that. So it's not something we're trying to do based on an emergency temporary standard, but something we have in place going forward. And I think they are receptive to that. And I think it would be really, really helpful to have something like that for all workplaces.
I agree with all those comments. I think one of the challenges that we face is that, because of recent events, vaccines are increasingly politicized. We're seeing state legislation that, not only prohibits vaccine requirements, but also is aimed at, prohibiting, vaccines. Not only opposition, but actual legislation prohibiting vaccine requirements, which could apply to vaccines beyond COVID. That said, even mandates aside, I think there are a lot of the tools that have been successful that I and the other speakers talked about, ways to increase access, ways to increase education, can also be valuable for vaccines other than COVID.
Jeff Duchin, you had your hand up again.
Thank you. In follow-up to this excellent discussion, I'm curious about how the employers are responding to the issue of booster dose documentation or requirements. It's one thing to require the primary series and get documentation of that, but we have a lot of challenges with our vaccine documentation system, I'm sure, across the country that exists or doesn't exist to various degrees, and then tracking a booster dose as well and potential future doses adds complexity. So I'm just wondering how you're looking at it with respect to boosters. And then finally, when we're talking about workplace safety from infectious diseases like COVID, indoor air quality is arguably as important as vaccination, certainly critical. And I'm wondering, are we sort of working in concert with those or advocating for indoor air quality standards, or how can we sort of, promote a more holistic, safe workplace environment in addition to vaccination?
Yeah, the booster thing, if I can take it just really quickly, it has been confusing. And I know we heard someone from CDC here earlier say that it hasn't been included in the definition of fully vaccinated because the data that is also coming out from all of our health experts says it is protecting you more, and it is, recommended in order to be fully as safe as you can be. I wish that definition could be changed and it could be included. It would help us a lot. It is some of the systems that people are using, and there's lots of different technology out there right now. Just record the two. And I think if CDC did change it, I think they'd hustle up and make sure that we'd have an easier way of capturing additional data, which we don't right now. So they do go hand in hand. And the ventilation, I know I brought it up. It's critical. That is one of the most important things that we can do in closed work environments where you have multiple humans within close proximity, is address the air quality. And I know that OSHA and others have had that on the list as well of recommendations, and we do too strongly. And there's guidelines from NIOSH on what that needs to look like, and any amplification we can do there is going to be game changing.
Thank you for supporting that.
So we have, as Center for American Progress, we've advocated for moving even more toward a definition of up to date rather than the current fully vaccinated, which I know CDC is moving away from slowly. As an employer ourselves, we have also required our own employees to be boosted because of the superior protection that boosters provide. And some states, including Connecticut, Massachusetts, and New York, have also required boosters for healthcare workers. So I think that is a trend that we see coming. On your question about ventilation, I think besides that, another change that I hope may stick is greater paid sick leave and paid leave for employees to stay home when they're infectious. I mean, we should make it less costly and easier for people to do the right thing, and also build a culture in which it's okay to stay home and with the new technology we have, work remotely if possible.
Thank you.
Well, I want to thank the members of this panel, thank the committee for your contributions to our discussion. We've reached the end of this panel. The one item of business we've got left for today is our public comment. I understand we have one public comment on the phone today from Teresa Wrangham. Ms. Wrangham, are you on the line?
She is. Teresa, can you dial *6?
Hi, can you hear me?
We can hear you now. Thank you.
You are loud and clear.
Wonderful. Thank you. My name is Teresa Wrangham. I'm the Executive Director of the National Vaccine Information Center. It was our co-founders that worked with Congress to pass the 1986 Act that created the National Vaccine Advisory Commission. It also put a research mandate into place to promote that ongoing research on vaccines and their safety and risks be conducted so that when Americans choose to vaccinate, they are vaccinating with the safest vaccines possible. I would say with regard to vaccine hesitancy and some of the comments I've heard today, there are many highlights from Institute of Medicine reports relating to causality statements and the prevention of causality statements from being made that are due to a lack of research being done today. That is a huge reason why people are hesitant. These are also, when we speak of COVID-19 vaccines, they are emergency use vaccines and have not gone through the same measures as a regular vaccine in terms of safety. This is a cause of concern. With regard to the presentation today by OCR, it was disappointing not to also have information on the protection of employees under Title VII and Title I to not be discriminated against and to be allowed a reasonable accommodations. We are receiving many complaints from employees about being harassed to get vaccinated. This is a violation of human rights. It is not a choice when you are forced to choose between your job and a vaccine. That's coercion. That's discrimination. And the informed consent ethic speaks specifically to the need for informed consent. It needs to be voluntary, and it needs to be without coercion for whatever decision is made. And while MVIC supports access to vaccines and the need to make sure that those who want to vaccinate do not have barriers, whether it's with regard to language barriers, financial barriers, etc., there also needs to be choice. Vaccines are not without risk. We are seeing the highest number of reports to VAERS to date since its inception, just for COVID-19 vaccines. And while it's a passive system, it's important to look at all of those, not just in the realm of background population, but to do the bench science to see if there are any associations to vaccines and to get research done so that if there are, we can get them on the vaccine injury table and make sure that compensation is happening as it should as an on-table vaccine injury. I appreciate the opportunity to make public comment today. Thank you.
Thank you, Ms. Wrangham. This ends the first day of our February NVAC meeting. I want to thank all of our presenters, thank the OIDP staff and the NVAC support group, and I want to thank all the committee members, our liaisons, and ex officios. Hope you all have a good evening, and we'll look forward to seeing you tomorrow. We will start again promptly at 1 o'clock Eastern time. And you all have a good evening, and we'll see you tomorrow afternoon.
Produced by the U.S. Department of Health and Human Services.